Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Richard Lawhern. He's a patient advocate. And the Kevin MD article we're talking about today, he co-authored, is U.S. Opioid Policy History, How Politics Replaced Science in Pain Care. Richard, welcome back to the show.
Thank you very much. It's a pleasure to be with you.
All right. So tell us what led you and your co-author, I believe is Stephen Nadeau, to write this article and share it on Kevin MD.
Well, Dr. Nadeau and I have been longtime colleagues and co-advocates in a process of basically challenging what we believe is outright healthcare fraud on the part of major U.S. healthcare public policy agencies. And we have, from his clinical experience in behavioral neurology, he is presently a behavioral neurologist with the University of Florida Medical Center. From his clinical experience and my experience as an advocate, we have carefully probed the literature on multiple subjects. If I might add a note of introduction for your readers, I personally have been active in this field for almost 3 decades. I am not a clinician myself. I am, however, a data analyst and healthcare educator with over 300 articles published, a good number of them with Kevin MD, in this field, and particularly in the field of public policy with regard to the prescription of opioids. So Dr. Nadeau has added and helped to shape and basically mentored me in the process of understanding how science and how politics have influenced the development of healthcare policy concerning the treatment of pain and addiction. One thing that we are aware of is that the public health policy has been controversial with regard to the prescription of opioids for something over 50 years. And dating all the way back to the Controlled Substances Act and the creation of the Drug Enforcement Agency, what we've seen is a steady erosion of clinician latitude or discretionary power in the practice of medicine that addresses pain management or addiction management. And Dr. Nadeau and I are both convinced that current healthcare policy is clearly wrong on both scientific fact and ethics. And it's wrong in ways that we believe the authors and reviewing officials of several of the opioid prescribing guidelines have known well before publication of their guidelines was simply not true. And that's the basis for our accusations of fraud. In the current article, what we are witnessing is that drugs prescribed for addiction management are coming to be used widely on the basis of CDC and VA guidelines for the treatment of pain. However, the literature behind those treatments, behind that use, reveals that these drugs are commonly understood to be basically very weak pain relief drugs. Their primary purpose is indeed in suppressing or providing an alternative. Methadone, of course, also does that. An alternative to people who are experiencing deep cravings for opioid drugs for a variety of reasons. And in that regard, what patients tell doctors these days is that, let's see if I can get this right. What patients are telling doctors is that the drugs that are now being seen as sort of a safe haven for clinicians, where they anticipate that if they prescribe those drugs, they're not going to be challenged by the DEA or by their state boards. Those drugs really have very little useful application in pain management. And patients tell us that they might take the edge off, and that's a phrase I've heard often. They might take the edge off the pain, but they don't really deal with it. In many cases, patients tell us that if one was to measure their pain on a scale of 1 to 10, a lot of their days are spent with pain at level 12. And for pain that is less than level 10, it's a little unusual for these drugs to reduce pain, for instance, buprenorphine, to reduce pain more than 1 or 2 levels on a scale of 10. And yet we're seeing those drugs and the drugs commonly used to treat neuropathy, which is a very narrowly defined disorder, are being proposed as substitutions for opioids. And that is simply scientifically unsupported. So going back and looking at this history, and this is what we did for the article you mentioned, which is U.S. opioid policy history, how politics replace science in pain care. From our combined experience of over 40 years in patient advocacy and pain management and behavioral neurology, we're convinced that U.S. public perception and public policy on treatment of pain have been driven almost entirely for close to 50 years by politics, not by science. They very seldom in recent years has policy of our major political agencies been driven by science or even significantly influenced by it. Now, for instance, in the late 1990s through about 2008, the US enjoyed a very brief period of scientifically enlightened policy. A large number of patients almost certainly benefited from that policy. However, tragically, patients who were treated with opioids were very soon to become legacy patients. They were made prime targets for involuntary opioid tapering. And although university medical centers might have provided some scientifically based countervailing force to the various non-scientific influences, most of the time they simply didn't. They just flat failed to do so. Beginning around the year 2000, corrupt physicians collaborated with corrupt pharmacies to create pill mills. And in these organizations, a 5-minute visit with a so-called clinician, who was basically just a drug provider, could net someone with a prescription for 1,000 pharmaceutical-grade oxycodone or OxyContin 30 milligram tablets, which would then be very promptly filled, and the so-called patient, quote, quote, would then disappear, often across state lines. Worse, the national drug distributors such as McKesson, AmerisourceBergen, and Cardinal Health strongly supported the pill mills. The pharmaceutical companies, particularly Mallinckrodt, Mallinckrodt, I can't pronounce it to save my soul, I'm sorry. They provided volume discounts to the distributors, and as a result, a tsunami of opioid goods flooded the country, and the vulnerable populations began to evolve to become the heart of the modern phase of what we're now calling the opioid crisis. So the decade from 2000 to 2010 was dominated by business corruption. In response, the DEA began prosecuting pill mills. The reason for that prosecution wasn't particularly transparent, and many, in fact, most pharmacists have since become fearful that dispensing opioids in any quantity would put them in risk. So from 2008 to the present, there's a pharmacy shuffle that's emerged. And by that, we mean that patients who had an opioid prescription issued by a clinician, and that was even a clinician with excellent credentials, could not find a pharmacist who would fill that prescription. And when they did, if the pharmacist was prescribing for any large number of patients, they might be absolutely put out of business by state attorneys general working with the DEA. So we are now facing a panic phase of the opioid crisis. And well-intended pharmacists have revealed that they are, after all, human beings. They're afraid for their own livelihoods, and they are refusing to fill legitimate prescriptions.
So what I'm hearing is that because of the DEA crackdown on opioid medications, a lot of these physicians, like you said earlier, are are prescribing medications like buprenorphine, some of the medicines that are aimed for neuropathy like gabapentin,
Yeah.
and they don't have the same efficacy as opioids. So, under that setting, where the DEA is cracking down on these pill mills and cracking down on opioid overprescribers, what is a path forward for physicians who do want to legitimately treat chronic pain?
This path forward is not going to be easy. Physicians are going to have to stand up and be counted, and they're going to have to do it in public forums, and they're going to have to do it in Congress. Basically, our congressional critters do not really understand medicine and aren't really interested in medicine because any subject that threatens their political contributions from hospital associations and from anti-opioid zealots simply doesn't get a hearing. And a phrasing on this that I have used in some of my publications and in my podcasts has been, we're going to have to convince legislators at all levels and state boards of pharmacy and of medicine at all levels that they must either reconsider their unjustified restrictions on opioid prescriptions, or they're going to have to find themselves confronted with the need to avoid being prosecuted for negligent homicide. Now, this is not a conspiracy as such, and it's not a trivial consideration. But reality is, and Congress must be convinced in both houses that it is, that present opioid policy that is promulgated by the CDC, the FDA, the Veterans Administration, and DEA is profoundly destructive. It is over politicized, and it is killing patients by the thousands by denying them pain care. And so, what we are trying to do is to bring this subject, in a sense, to a head by repeatedly publishing the real science, which largely has not been acknowledged by the DEA, and by assisting doctors to defend themselves in adversarial proceedings. Those adversarial proceedings have literally thrown at least hundreds of clinicians into prison, and they have forced thousands of clinicians out of pain management. That's not acceptable. And the public realizes it's not acceptable. And that's basically the purpose that Steve Nato and I have undertaken, along with a rather large network of other physicians who are also writing in this field.
So let me ask, in terms of the current narrative of the opioid crisis, where you have the addictive potential of opioids taking forefront now, how do you square that narrative of opioid addiction with appropriate chronic pain treatment, sometimes needing opioids?
Okay, squaring the circle in a sense. What we have done by analysis of the literature is that we have demonstrated very conclusively and from multiple sources over the last 16 years that the addictive potential of opioids is far lower than has ever been acknowledged by the public health agencies. In fact, I will be giving a presentation in Roslyn, Virginia this coming March to a harms reduction conference called SYNC 2026, where I've been invited by the DC Department of Health and a harms reduction outfit called Health HIV to present an indictment of the public health policies of our major agencies based on published data. And that published data shows us, and this is really essential, that the so-called addictive potential of opioids affects fewer than one patient in 1,000 who are treated. And we have multiple sources for that, and I can quote them for you. And as a matter of fact, I have quoted several of them in the work that we've done together on Kevin MD. So the science simply does not support the position that's being taken by the agencies. And Congress has to fix that because DEA and those agencies are never voluntarily going to let go of their distorted positions on this. CDC has demonstrated this conclusively because they have published two guidelines, one in 2016, the other in 2022, 23, which flat out ignored the science. And not only ignored it, they misrepresented the science. And that's proven just by reading these documents. Anyone with an appropriate understanding of the medical science that surrounds this issue will tell you, and any doctor will tell you, opioids are among the least toxic medications used in medical science. And let me give you an example, if I may, and please interrupt me if you feel like you need to. We know, for instance, that many people who are imprisoned with having a history of drug use have acclimated to a dose level of opioids that you would measure not in milligrams of morphine, but in grams of morphine every day. That's like 2,000, 3,000 morphine milligram equivalent daily dose. It is only when they are weaned off of those opioids while in prison and then are discharged later that they overdose because they come back to the original dose levels that they experienced and were taken off of too rapidly. Now we can ask a question about this, and it's a serious question. This is not a trivial issue or a distortion. What other medications do we know that can be tapered to a level 50 times the recommended maximum dose without killing the patient? Opioids are one of those medications. The consequence of that is simply that what we are recommending and what we have demonstrated in many of our published papers, and one of the best that Steve Nadeau and I were active in, is called the two opioid crises. It's in Frontiers in Pain Medicine about 3 years ago, and it's being very widely cited right now in the literature. One of the things that we've recognized is that the guidance that's being provided by the agencies flat out and fraudulently ignores the reality that there is an enormous range of tolerable dosages among people who are treated for pain using opioids. That range is at least 15 to 1, and we know why it is 15 to 1. And the why is never once mentioned in CDC or FDA or DEA proceedings. It's never mentioned.
Now, what's the motivation? What's their motivation for overstating, according to your data, the addictive potential of opioids?
Money. There is enormous money, and it's traveling in very hard to trace circles. But basically, money and professional dominance and a certain degree of emotional denial are all operating in the policies of these agencies and in the activism of anti-opioid zealots. People who've lost a kid to opioid addiction or overdose want somebody to blame. Doctors who have staked their professional reputations on anti-opioid positions are quite willing to distort the science to defend themselves from basically being forced to retract what they've said up to now. Politicians don't give a rip one way or the other unless it generates campaign contributions. And we all know that Congress certainly does not act on behalf of constituents until they are bludgeoned half to death. And I realize I'm being a little confrontive on that, but that's the way the system works.
Mm-hmm.
So the motivation here is that there's a lot of personal prestige and there's a lot of money from healthcare insurance companies that is basically invested in the proposition that the more chronic pain patients we can kill off, the higher our profits will be. And this is not an extreme position. At least I encourage those who are seeing our podcast to realize this is not an extreme position. This is a position that is taken by tens of thousands of people in social media who are patients, who have seen how this operates, who are doctors and have been personally persecuted by a state board or by a DEA. One of the members of my speakers bureau in the National Campaign to Protect People in Pain is a doctor who was successfully prosecuted, persecuted, and imprisoned for 7 years by the DEA and by its pet anti-opioid expert witnesses in a proceedings in which, if you basically review the proceedings, you realize that what really occurred was a kangaroo court. The judge himself was absolutely convinced that nothing that the defense had to say would make a bit any difference at all, and he denied the defense actively any opportunity to challenge the qualifications of those who testified on behalf of the government. This is not unusual. I have seen it repeatedly, and other doctors have seen it. Doctors more qualified than I have seen it among in the court proceedings that have occurred against clinicians. So, to answer your question or reprise on your question, money is the answer to this. The more patients the insurance companies can kill, and I'm not being extreme here, the more they can kill, the higher their profits. You know, we had an incident a year ago in New York when a healthcare insurance company executive was killed, and the the court proceedings have now been denied, been denied for over a year, and effort is being made to move them out of the city of New York for a basic reason. The prosecutors are not convinced that they can get a conviction with any jury that has on it someone who's been mistreated by an insurance company. That's appalling, but runaway juries basically realize what's going on here. They realize that the corporate executives deliberately deny them care because the company doesn't want to pay. It's no more complicated than that.
We're talking to Richard Lawhern, patient advocate. Today's Kevin MD article is U.S. Opioid Policy History, How Politics Replace Science in Pain Care. Richard, let's end with some take-home messages that you want to leave with the Kevin MD audience.
Okay, basic messages. One, I personally can be contacted at Lawhern, that's Lawhern, at hotmail.com. I head up a national organization of over 1,500 patients and doctors that's called the National Campaign to Protect People in Pain. We have an excellent website, fresh out, that you can come to amplify on these themes, read the literature, understand where the factors are that you need to account for. It's called ncp3-advocates, advocates.org. We are here for you. We invite you to join as either patients or clinicians, and we intend to force the retraction of all CDC and FDA guidelines on this subject in favor of doctors functioning with evidence-based practical medicine without the interference of state agencies. Our mission is a large one. Come join us and help us do it.
Richard, thank you so much for sharing your insight. Thanks again for coming back on the show.
Thank you very much.